Good morning.
Good morning.
Let's wait till 7. Okay, why don't we get going? All right, so this morning we're going to talk briefly about Sodalol. So Sodalol is a non-cardioselective beta blocker. It was introduced in 1970 actually as an antihypertensive agent, but later was determined to be a class 3 agent or a potassium channel blocking agent. So it has both beta blockade effects as well as potassium channel blockade effects. And this is important because oftentimes I've noticed that some people mistake it as exclusively a beta blocker. It is a good beta blocker, but it also is importantly a class 3 agent. So when we think about Sodalol, most of the beta blockade effect you'll see at the lower dosage, meaning that even at the starting dose, you get about 80% or more of the beta blocker effect. But the class 3 effects or the the potassium channel blocking effects are typically seen at the higher doses. And it causes prolongation in the action potential in the atrium and the ventricle. And it will prolong the QT interval, which means that it enhances the risk for torsades. So you have to be careful with this agent. And when you're starting it, you want to get an EKG every day to monitor the QT interval. This is, again, the effect of Sodalol on the action potential, lengthening it out. It is very well absorbed from the GI tract, and peak serum concentrations are 2 to 3 hours after administration. The half-life is 7 to 8 hours, and it's even shorter in children. And it is not metabolized, it's just excreted by the kidneys. And so when a patient has renal insufficiency, one needs to reduce the dose. That's an important point. The dose in children is 80 to 180 milligrams per meter squared per day. Some groups will go as high as 200 milligrams per meter squared per day. And in adults, the starting dose is 80 milligrams PO BID, and it can be increased up to about 160 BID. It also comes as a 120 tablet as well. In terms of what do we mostly use it for? It's used for treatment of SVT commonly. It can be used for atrial arrhythmias or ventricular arrhythmias. And more recently, there is an IV formulation of Sodalol, which has been reported in multiple different small reports for use in many different arrhythmias. It has even been used for junctional ectopic tachycardia and SVT and even VT. And it, I think what a lot of authors use it is essentially if you know you're going to be going to oral Sodalol and somebody has an acute arrhythmia, they'll use IV Sodalol to get the level up relatively quickly, especially if the patient is NPO. When I was at the HRS meetings, Ellis Rochelson, who was a fellow there until recently, reviewed a recent report from there looking at about 70 patients who received IV Sodalol showing efficacy that was certainly, I would say, at least similar to amiodarone, if not superior for certain different arrhythmias. Okay, so that's it for the drug question today. I apologize. It's going to be a slightly shortened meeting. I'm not feeling 100% today, so I apologize. So this is a LAO view of catheters in a patient having an ablation. So the question I'm going to ask is, where are the catheters? So why don't we start with Tarek? Tarek, I'm going to just point to one of the stars here, and so maybe you can tell us what you think we're looking at here. So first of all, what is this catheter? Where is this sitting? I think Tarek is...
I think, yeah, that I think is going through the, coming through the SVC.
Mm-hmm.
And then I think in the ending in the left atrium.
It is on the left side. That's correct. Yes. So it's in the coronary sinus. So you haven't done cath yet, of course. So it's a very unfair question. But this is a coronary sinus catheter that's placed from the superior vena cava down into the CS here. Let me, good answer. Let me ask David. David, where is this catheter?
Is that the his catheter?
That's exactly right. And Dave, what is this catheter here?
High RA.
Correct. And this one down here?
So that one I've been kind of thinking about because it looks like maybe a low right atrium, but I don't always see you put a catheter there.
That's correct.
Like
So any other thoughts?
Let me see here.
Well, what is it? While we're waiting on that one, what do you think this is here? This is the easiest one.
Is our RV?
Are you talking about this or this?
Let's see here, we're LAO. So I think that the lower one would be in the RV, one that I was talking about before.
Yeah, that's correct. And what do you think about this catheter here? So this catheter is going transeptal across the atrial septum into the left atrium, and is on the mitral annulus. So when you're looking at an LAO view of catheters, sort of think about this as being the mitral annulus with the coronary sinus sort of surrounding it. And then on this side, similarly, the tricuspid annulus. And this is the his catheter is typically sitting in the anterior septal region. And so when we are describing where we successfully ablated a pathway or where a pathway we thought was, we'll typically consider this like a clock face. And you may see in our reports that, the catheter is at like, 215 on the mitral annulus. And that's what, with 12 o'clock being here and 6 o'clock here and 9 o'clock here, or I'm sorry, 3 o'clock here and 9 o'clock here. So we would say, on the mitral annulus, this would be considered left anterior lateral because it's not straight lateral. And we would say around 2 o'clock or something like that. Okay. All right. So I see our friend Sonny is here. We're going to torture him, even though he is a non-invasive imager. So Sonny, this is an ECG recently obtained on a patient that says, and the ECG says, patient has sinus bradycardia with right atrial enlargement. Do you agree with this?
How old is the patient?
How old is the patient? This patient is, I think this patient is 2 years old.
Okay. Well, the bradycardia part is right. The sinus part. It looks like there may be a P wave buried in these T waves. So they look a little early. So I'm suspicious that these might be blocked PACs or some non-conducted atrial beat.
Yep.
So I wouldn't call it sinus bradycardia. And then the right atrial enlargement part, sure, I think the P waves are kind of tall in E1.
Right.
So
Agree. So this is some kind of heart block, right? Because I think if you look particularly in lead 2, you'll see that there's appears as if there's 2 P waves for every QRS, right? P wave, P wave, P wave. And if you had calipers, you'd see that these are marching out.
yeah,
So this patient doesn't actually have sinus bradycardia, but is bradycardic for sure. So this patient actually, so from this tracing, you would say that it's 2-to-1 heart block, but in fact, this patient has complete heart block. It's just that you don't have a long enough tracing in order to confirm that. But if you watch this patient over a Holter or a Zio or something like that, you would see that there are that there's no relationship between the P wave and the QRS, even though it does appear on this tracing as if there is. So this patient has complete heart block. And so let me ask Grace. Grace, if you had a patient with complete heart block and you knew this was congenital, how would you be monitoring this?
I would do a Holter every now and then, look at the average heart rate,
Mhm.
and
And
regularly.
what are you looking for on that Holter? So you said average heart rate. That's absolutely true.
The AHA guideline, I think, in children less than 55 would be an indication to put in a pacemaker.
Well, it depends on the patient's age. But yeah, 50 to 55 is the range. Is there anything else that would concern you if you saw a Holter? So let's say you did a Holter and the average rate was 70, so you're okay from that perspective. What else would you be looking for on that?
Complete heart block already.
Mhm.
Do you look for variability?
Well, generally speaking, people in complete heart block are not particularly variable. Yeah, their heart rate over hours will change, of course, but over a general strip, it doesn't usually change very much. You're also looking for big pauses. I'd have to. There's actually new recommendations that just came out, so I'll forward them all to you today. It literally came out 2 weeks ago, and one of the things, which has been in it for a while, is if there's a certain length of pause, I think it's like if it's 2 or 3 times the basic cycle length suddenly, that would be a reason. Or I think now they just call it long pauses. That would be a consideration for a pacemaker. Also, if you have a wide escape rhythm, like you're having essentially an idioventricular rhythm because the narrow QRS is not coming in, that would also be an indication for a possible pacemaker in a patient. So, and then most importantly would be symptoms. So if the patient has symptoms of chronotropic incompetence, that would be a very strong indicator for a pacemaker in someone with complete heart block. And sometimes that can be challenging in a small child to completely understand if they're having symptoms. But that is a class 1 indication, is someone with complete heart block who is symptomatic. Obviously, if they're fainting, that's pretty obvious. But if they are having, just generally mild, lower than average energy levels, that's harder to gauge. But usually mothers are fairly good at telling us the answer to this one. Okay. All right. I'm going to ask Tulsi what you think about this. This is from a Zio patch on somebody. And I'd like to know what you think about this rhythm and if you think there's any treatment that's needed or anything like, or what you might do to evaluate the patient who has this.
Good morning. So it looks bradycardic, just based on how the apparent QRS complexes are spaced. And they do look wide.
Well, I mean, I didn't give you an age on this patient. Let's say
got
the
it.
patient is 12. So do you think this is bradycardic? I mean, what's the heart?
Yeah, that's true. Sometimes probably like somewhere between 100 and 100. Just under 100.
It's actually even slower than that, right? But it's about 75 beats per minute, roughly, right? The heart rate.
Okay.
So I wouldn't say he's bradycardic.
Okay.
Anything else that strikes you about this rhythm? So you said the QRS is a little wide. I agree, it is a little wide. Are we in sinus rhythm?
For the most part, I would say yes, but it looks like there is a missed beat. I don't know how to read this, but like in the second row. Yeah.
Yep. What do you think? Anything? Let's just look at the top row. Anything that would jump out at you about this rhythm?
The PR looks really long.
That's right. So what's the other way of saying that?
They're in heart block, like a first degree heart block.
Right. So this exactly. So this is first degree heart block with a very long PR interval, like almost 400 milliseconds, right? Then we have this P wave that drops. So this is first degree heart block, and then we see that there is this P wave which is not conducted. So it's hard to know what the level of conduction block is here. But I think if you took out calipers, you might notice that there's a slight prolongation in the PR interval from this beat to this beat. So this is most likely Mobitz 1 or Wenckebach conduction. This was obtained, I think, when the patient was sleeping. So, when you see a person who has first degree heart block, what are some of the causes of first degree heart block that we would want to check?
Medications.
Okay, yeah, so it could be on some high doses of arrhythmia medicines can cause this, tricyclic agents. Okay, let's assume those are not the case. Tricyclics mostly they'll cause prolongation in the QT interval. What else could this be?
Maybe electrolyte abnormalities.
Okay, yeah.
And then, sorry, what was that?
No, go ahead, please proceed.
And then infection.
Right, if you had myocarditis or endocarditis, you could have a long PR interval from those. Yeah, that's certainly possible. Any other possible causes?
Structural abnormalities.
Yeah, you could have a surgical injury as a result of surgery, or you could have patients who, we've talked about this in the past, patients with L transposition have a higher incidence of heart block in general. So it could be an L transposed patient or somebody who maybe had a VSD closed or an ASD that was inelegantly closed. Any other medical causes of a long PR interval? Well, you could have
Like endocrine. No, sorry.
Exactly. Hypothyroidism can cause AV node dysfunction. So you would definitely, I remember well, I used to have a patient who has hypoplastic left heart syndrome, and she had congenital hypothyroidism. And when she became a teenager, her mom allowed her to take her own medication. And one day she came into the office and her PR interval was like almost as long as this one. And she had never had a problem with her PR. And I asked the family and the patient if she was taking her Synthroid, and she was adamantly said that she was. But I got a phone call from the car about a half hour later that on the way home, she admitted that she wasn't taking her medication and she was very hypothyroid. And this normalized when she started taking her Synthroid again. So hypothyroidism is always a concern. Lyme carditis is a concern as well. Okay, and I think this will be our last one this morning. So this is a 12-year-old with a fenestrated Fontan during catheterization for closure. And the patient has this rhythm. And this is a high RA catheter. Essentially, the cardiologist has placed a catheter in the heart because of this somewhat irregular heartbeat. So I am going to let me ask Perna what she thinks about this rhythm.
Hi, Dr. Bass.
Hi, Perna, how are you?
I'm just trying to correlate with the surface leads, the HRA catheter. And CQRS correlating. Wait, this one is, so in the first beat itself, looks like the P wave or the A wave is after the QRS, that corresponds to the surface EKG.
Correct, yes.
And then following that, then there is a wave on HRA, then there is then again an HRA that is not conducted, or there is significant AV interval. This is like, it's a Fontan patient. There are more A's than B's. I would say atrial flutter or IART, intra-atrial reentrant tachycardia.
Yes, so it could well be that it is intra-atrial reentrant tachycardia. The fact is that the R to R interval is clearly not regular, right? We see here that this R to R is longer than this R to R, and this R to R is sort of in between the two. And so I agree with you. I think this is some form of IART. And one of the interesting things about IART in Fontan patients is they're not often very fast, right? When we think about atrial flutter in an older patient, we think about the rate being like, I don't know, I'll make it up, 150 in the atrium. But you can see, I apologize, this is a lousy copy, but the atrial rate is not especially fast here. It's like 75 beats per minute. So, so it's hard to know. This could be IART at 75 beats per minute. It's also possible that this could be sinus rate with some kind of AV nodal injury potentially related to the catheterization. You know, when we place a catheter, when you're in the Fontan, it's hard to cause heart block, but when you cross the fenestration, then you're getting into all the good stuff on the inside of the heart. And so it isn't inconceivable that you could touch the AV node. So it's hard to know what this is. It seems like it does seem though like there's some kind of AV block of some sort, because where I don't really know. Maybe that's not true, but there is definitely some conduction, because probably this beat here, for example, is conducting to this QRS, maybe, which may explain why it's earlier than say this R to R interval. It's hard to know, but there's definitely, doesn't appear as if there's an obvious relationship between these P waves and QRSs. This could be a form. I think this is maybe Wenckebach at a very slow rate. You know, like you could argue that maybe this P conducts to that QRS, this P to this QRS, and then this does not. And then this P conducts to this QRS, and this with a longer PR to here, and then this does not. So this is probably some kind of, maybe it's Mobitz 1 with either IART or sinus rhythm, and some kind of AV nodal issue. This is always a concern when we're doing a cath on somebody who's a Fontan, because it's hard to leave the lab. You know, it's hard to pace these patients, right? Because we don't have transvenous access to their ventricle. And so if a patient ended up with an AV nodal injury like this in the cath lab, they would certainly need, and they didn't go into the lab this way, they would probably need a, need to be in the ICU, and they might need a semi-urgent epicardial pacemaker. So if this were a transient event, hopefully it would resolve. When you get heart block, Perna, when you get complete heart block in the cath lab, do you know how often it is that it gets better on its own? You know, so let's say it's not uncommon when you're passing long sheaths across the RV outflow tract and across the tricuspid valve, that the wire or the sheath may bang into the His Purkinje system and cause heart block. Similarly, if you're doing a Fontan fenestration closure, your catheter or your guide wire in the atrium could potentially tickle the AV node. Do you have any idea what, if you came out of the lab in heart block, what percentage of those patients recover?
I want to say 80 to 90%.
Actually, it's about 2/3. It's a little less good than that. Now, it's a little bit of a general statement. I do think, and I have noticed that if you're very careful when you're doing a cath and you notice the problem and address it immediately, in other words, as soon as you start seeing non-conductive P waves, you remove the offending wire or the sheath, or I think that the chances are much better. And this is an important point, particularly for you, Perna, since you're interested in cath, or anybody who's interested in cath, Sergey. You always want to look at the EKG. You know, we have a tendency in when we're cathing to sort of almost forget about it. But, you know, I do have a strong bias that if we are carefully monitoring the ECG during a cath, and you see a problem of this nature and you pull out a catheter that might be touching the wrong area, I do believe the likelihood of recovery is much greater than, you know, now there are some cases where we have no option. For example, if you're putting a melody valve out and you're having difficulty getting the assembly out the outflow tract, and you're having to really struggle, you're not going to stop when you have heart block like this, because it's just, sometimes it's taken you an hour to just get everything ready and get the wire in proper position, et cetera. But in circumstances where you're just doing a diagnostic study or you're just starting to place wires, when you start to see things like this, one needs to be aware of it and immediately respond appropriately. So I think with this, unfortunately, I'm going to have to stop, and appreciate you joining me this morning. I'm sorry we're a little bit abbreviated, and I hope everybody has a really nice day today. Thank you.
Thank you.
Thank you.
Thank you.